Good evening, dear colleagues and friends. Good evening for all my friends in Chandigarh. I would like in the beginning to thank the president of Chandigarh, Dr. Gaspret, and also the Professor Shantan for their kind invitation for MIOM to participate in Chandigarh Ophthalmic Society. I am Dr. Muhammad Al-Amri, the president of MIOM. And I would like to introduce my dear colleagues who are with us today. And I will start with the panelists. My dear friend Nazim Al-Hussein, he is a vitreoretinal specialist, Medical Parkview in Dubai, UAE. He is a vitreoretinal surgeon. The second panelist is Dr. Sandeep Mitra. He's a consultant of ophthalmology at Al Zahra Hospital in Dubai. He's a cataract and refractive surgeon. My dearest friend, Dr. Madhav Rao, consultant ophthalmologist, vitreoretinal surgeon, and he is working in Abu Dhabi in the Borjil Hospital, head of the department. Okay, next, please. We are having two sessions. Actually, in one session, we are having divided into two parts. The anterior segment sessions, we are having the first one, Dr. Safwan, but the one who is going to present first is Dr. Usama Safwan Al-Bayati, consultant ophthalmologist, phaco-refractive retina surgeon, founder and medical director, New Vision Eye Center, Dubai. We are having Dr. Ashraf Armiad, my dear friends, consultant eye surgeon, a shareholder of Al Wataniya Eye Hospital, Cairo, Egypt, Wataniya Research and Development Center in Cairo. Also, my dear friends, Dr. Usama Al-Jlaidi, consultant ophthalmologist, Moorfield Eye Hospital. He is a cataract and refractive surgeon. This is the first session. The second session, it will be posterior segment session. We will have also an eminent speaker. This is myself. Already I introduced myself. We go to the next. My friend, Dr. Patricio Lorenzo, consultant medical retina, and he is now in Dubai Hospital. I think he changed his place. Dr. Patricio, you are with me? Can
Yes,
you hear?
yes,
Yeah,
yes.
I think that you are now in the place in.
I'm in Kiron Salud,
Yeah.
Institute in Dubai.
Yes, now he's changed his place. Okay. And the last and the least, our friend also, Dr. Ziad Madanat, he's a research fellow in Bradford Ophthalmology Research Network, Bradford Institute for Health Research in UK. Thanks for all for being with us. And now we will start our scientific meeting, and our first speaker will be Dr. Usama Al-Jlaidi, and let us see what Usama prepared for us, a case presentation. Dr. Usama, the mic with you, please.
Hi, good evening, everyone, or good afternoon, other people. Thank you for this invitation. Is the screen there, okay?
Yes, go ahead, Usama.
So basically, I'm going to talk about toric IOL for astigmatism management in cataract surgery as case presentation. So my case presentation is 55 years old lady, came with secondary opinion because she had multifocal implant. Yeah, can you hear me? Is the slide moving?
Yes,
Mohammed?
Usama, we can't hear you.
We can hear you. We can hear him.
So basically, she came
Sama?
to, yes, they can hear me. I'm not sure it's your side, Mohammed. Let me know if the other people cannot hear, please. So basically, she had multifocal implant, toric
Dr. Usama, can you hear me?
I can hear you. Mohammed, is the other people can hear me or not?
Yes, sir, we can hear Dr. Osama here.
We can hear you, doctor.
Okay, so I'll go ahead.
Usama can hear me?
I can hear you, Mohammed, but I didn't
other speaker, they can hear me?
Yes, sir, Dr. Amri, we can hear you. We can also hear Dr. Osama. Maybe there's a network issue at your end, but we can hear him. We can see his slides also.
So basically, patient 55, she had multifocal implant 1 year ago, both eyes, but she's not happy with the vision right eye. Her uncorrected visual acuity right eye 2025, left eye 2020, and she had 1.25 astigmatism in manifest and autorefraction, but that improved her vision to 2020. Left eye, she had half diopter astigmatism. So when examination, everything looked clear, cornea clear. Patient, she had temporal cornea incision, the multifocal, she had good centration, no BCO, and everything is good. I asked her to bring her surgical report, why she had this astigmatism after the cataract surgery, the multifocal. Patient basically went for cataract surgery looking for freedom of glasses to see vision distant and near clearly. When I looked to her previous, when she brought her medical record, patient biometry in EYEMaster, so the cylindrical reading, it's minus 248 astigmatism, and the surgeon based that calculation, his calculation, and he also added the surgical induced astigmatism 0.33 at 180. So the calculated power for toric IOL is 21, but 3.5 astigmatism, and that's what the patient had it in the right eye. So basically, the patient was not happy because she had flipped of her astigmatism from with the rule to against the rule. And that really basically because she had the wrong K reading in EYEMaster. A preoperative patient doesn't use much astigmatism, but I look at the autorefraction before surgery, she had 125, 124 astigmatism, and postoperative that it was ended with against the rule astigmatism. So that flip the axis make the patient completely very unhappy. And if that surgeon look carefully to his K reading, for example, he know that the EYEMaster in this patient was completely wrong reading, and if he uses the correct K reading from repeated EYEMaster and the K reading, or the pentacam, this is the pentacam we did after surgery, so also show consistency. She has less astigmatism than what the EYEMaster measure, and the total cornea astigmatism, which is very important because the posterior, she had less astigmatism, so the total cornea astigmatism, it was 1.4. So patient ended with overcorrection because of the wrong K reading and not include the total K reading in the treatment. So the option for this patient, you could do IOL exchange or laser vision correction. First, I advise the patient to wear full-time glasses to make sure that her vision is happy with the glass before I do any procedure, which is very important for anyone who had multifocal implant. Make sure that the patient is very happy with the correction before jump to do a surgery. Basically, it's very important when you consider astigmatism correction for cataract surgery, you need to assess the regularity of astigmatism, always measure the degree and the axis of astigmatism by all different machines, autorefraction, refraction of the patient, EYEMaster, or any optic biometry, included topography. It's very important to do topography for any patient going to treat him for astigmatism, especially for multifocal, because that will tell you the total astigmatism, but also it's very important to know that patient is suitable for laser top-up if needed. Like this pentacam, patient had he had keratoconus, is not good for multifocal, and you know that you should avoid it from the start. So very important to know the degree and axis of the astigmatism, and all should be consistent with different measurements. Remember that traditional K reading alone, it measures the anterior corneal curvature, but doesn't measure the posterior. So extrapolated the posterior corneal curvature, which is almost 15% of our patients may not follow the normal predictable nomogram. Koch reported that if it's with the rule astigmatism, we tend to overcorrect it, the posterior curvature, and with the rule astigmatism, we tend to undercorrect it if we're using the anterior surface only. So it's really very important nowadays to measure the total corneal power of the cornea. And nowadays, there's many machines, device available, Scheimpflug or OCT, which will help. And that's really, you should use it for anyone consider astigmatic correction. Always remember that the surgeon should measure what surgical induced astigmatism for his case. Remember that temporal incision will induce less astigmatism, and also the smaller the incision reduce this. But it's very important for every surgeon who need to know how much he's induced and included in the calculation. And you could use different software for toric IOL calculator. If you are EYEMaster 700 now, it's very good, handy. It will give you the total calculation. Otherwise, you could use online, different platform, which is available nowadays to measure you that toric component of the IOL measurement. It's very, very important. Also, you need to have accurate marking and for the alignment of the toric IOL, either use manual, or nowadays we had also digital devices which will help us. With any patient, you need to consider astigmatic treatment. If you need to make sure that regular astigmatism, you need to do all the measurement with all the measurement consistent with the axis and the degree. Any astigmatism, basically more than 1 diopter, even in monofocal, is better to treat it. For multifocal, you need to have much lower threshold. More than a half diopter astigmatism, you need to consider at the treatment with different modality, either with incision or with limb relaxing or using toric IOL, depends on the degree of astigmatism. Always aim to end it with slightly with the rule astigmatism. Never try to avoid anything to correct the astigmatism and flip the astigmatism, because flipping the astigmatism always, it can cause more problem and symptom to the patient. So message taken home, really, all the measurement when you consider astigmatic correction, refraction, AK reading, mass topography should be consistent in the degree and axis. Always better to use the total cornea astigmatism measurement, avoid flipping the axis. Always with any multifocal lenses, you always understand the patient motivation and expectation, because and also make sure you had a plan to deal with post-operative refractive error, like laser vision correction, and not delay it too long, because the more delay for the patient after surgery, you create him more unhappy, and then you're looking for a different opinion. And so always to have a clear pathway and a plan to treat this patient. And thank you very much.
Thank you, Sama, for an excellent presentation. If we can go for discussions, is there any question from any in the panelists? Dr. Ashraf, Dr. Safwan, Dr. Sandeep, you are with us here?
Yeah, I want to ask Dr. Osama, in this case, and the patient has a form of keratoconus, so excluded laser vision correction for this case. So
not this case, no, that's not her scan. The scan is normal. No, the keratoconus, that's another patient. Make sure that you need to do pentacam. No, for her, pentacam is normal.
So what decision you
just a BRK. I did BRK.
Just BRK.
For her. Yeah.
And there is any tips when you do the laser vision correction post multifocal IOL?
Just very important, really, to make sure that the patient is happy with the vision, either with the glass or contact lens, before touching with surgery. And also the dry eye, make sure there's not much dry eye, because that may change the plan for the treatment.
Any situation about the angle kappa, and if it's large or no during the centration of the laser vision correction?
Yeah, but if the lens is decenter, that's different. You have to deal with the lens, because as I mentioned, that's why it's important to have a glass or contact lens, makes patients happy. Then if it depends on angle kappa, usually use a halfway, the centration of the treatment between the visual axis and the center of the pupil.
Thank you.
Dr. Safwan available here? Please have any comment? Dr. Sandeep? Okay, we can move to the next speaker. Dr. Ashraf, please, if you can start and share your...
Thank you so much, Dr. Mohammed, for the kind invitation, and thanks for the committee of this great meeting. Do you see my presentation?
Yes, just in slideshow. Okay.
Okay.
Yes.
So this weird case happened to me since 3 months. It was uneventful femtolasic surgery for a doctor. So this is a male patient, age 27 years old. His refraction was minus 4.5 diopter for both eyes. Best corrected with 1. Pentacam was normal with no abnormality. Operation went smoothly with no issues during surgery. Second day post-operative, best corrected was 1 in each eye bilateral. On the 4th day, the patient called me and said that his vision in the right eye was decreased. On examination, revealed the right eye best corrected visual reached 0.2. Sublab transparent mass seen with refraction of -6 sphere and 4.5 cylinder. So it was, for me, it was the first case in my life to happen like this. So this is his pentacam before the operation. Everything, I review everything. So I went to the pentacam again. Everything was perfect, nothing abnormal. And this is his picture on the photoset lamp after 4 days post-surgery. You see this weird area beside the pupil. More magnified, I found this. This is just 4 days post-operative. Localized area like this. And more magnification, it found like this. Like, I don't know, it's epithelium, subepithelium, it's mucin, I don't know. But this is more central and the patient completely unhappy. I reassured the patient. I did an anterior OCT to see what is the problem. So I found this mass under the flap It is a fusiform under the flap, and you see it is that this is the flap, and it making the above the flap is very thin, and it is fusiform mass. So I did the epithelial mapping also and found this irregularity in the epithelium. So I reviewed the operation. It was mostly nothing happened to anything, and the flap was okay, edges is perfect. So I took the decision before I asked more consult. I asked consult Arthur coming. He said, I don't know about the case. Tamer said another opinion. Dr. Fathi, Dr. So it was my decision to elevate the flap as soon as possible on the 5th day to decrease the incidence of subflap fibrosis and distortion of the epithelial cells modification, which may affect the quality of vision later. So this is in these cases, very important to mark the area you are seeing, because once you elevate the flap, everything will be transparent and you can miss the area you are seeing on the slit lamp. So very important to mark it before you elevate the flap. Like what I'm marking, see, with the trypan blue, I am marking the area I am seeing on the slit lamp before I invert the flap. This is very important. Drawing as much as you can to reach the edge to decrease the incidence of epithelial loss, which can happen as you're going to see now. So I reach the plane. I'm trying to be away from this to make it in the last part. Then I elevate the flap. Once I elevated the flap, you're going to see the same area I marked, I can see the area now. This is very important because you are going to deal with an area of transparent part. I washed first the bed of the stroma, and then I am dealing with this area. You are going to see it's like a mucin epithelial cells, I don't know. So I removed, I correct perfectly, because to remove any debris or any things will going to happen. Then washing as normal, I wash normal, return it again, drying, and putting a contact lens at the end, which is very important. Make sure you dry and best alignment for the edges. So post-operative, how I see, you are seeing it's perfectly. You cannot see the area, just mark of the end. And on high magnification, I can't see anything now. I removed it totally. And the best and uncorrected visual reaches 0.25 -5 after 1 week. I did an anterior OCT again to make sure that anything is not here again, and I found it completely clean. And you see how the epithelial mapping improved a lot. And this is how it before and how it's now. It's completely changed. So I looked for the lecture. It's an epithelial ingross, maybe you can see, but it is not the shape as I found in my case. And I look for another images of the epithelial ingross. I can, or epithelial implantation, different totally than I saw my case. So my final words. Very important to be close post-operative examination for your refractive surgery patient. Never feel ashamed to consult your colleagues, even in a situation like this, as I do refractive surgery since 2007. Don't hesitate to take the right decision in the proper time, and everyone can face problems, but the best is who can solve his problems. Thank you so much for listening.
Thank you very much, Dr. Ashraf. An excellent case presentation. I wonder what is things that was under the flap. Did you make your mind?
It's for me, I think it's epithelium growth, the primary one. When the surgeon lifted the flap, he implanted the big piece of epithelium, a sheet, and that's the most likely the cause for that, really.
I thought about this, Dr. Osama, but I am following the patient now for 3rd month. Nothing seen in the because I'm going to present this case with more and more in the coming ESRS. I made an anterior OCT again I made an epithelial mapping again. I didn't find any changes either in the picture or in the epithelial mapping. So I wonder if it's epithelial ingrowth or epithelial implant, I mean, or epithelial or mucin was under the flap. Mucin part.
But
I don't know,
Can we
because I
have
didn't
Dr.
like a-
Sandeep opinion,
But like
please?
a tissue, it's like a tissue you lifted. It's like a tissue, a piece of epithelium to me when you lift it. And it's also thick. When someone
Sandeep, what do you
lifts
think?
the flap,
Sandeep,
that will
you are
happen.
there?
Yeah, I think it is, to me, it looks more like a mucin. Sometimes it looks like an epithelium. But the problem is the epithelial ingrowth, it looked very different. Normally there is a gap between the edge from where it grows, you know.
No.
So I really don't know. I mean,
Sandeep, what I mean, Sandeep, this is not epithelium growth where you growing from the edge. This is when you lift the flap, a piece of epithelium, like a loose epithelium, you lift it under the and the flap. So a small piece of epithelium, when you lift the intralace flap, you could have a small piece implanted under the flap and keep it under the flap, and that's the piece of epithelium because it's thick, really. And it looked to me, is not, but not like the normal epithelium growth where it's growing, you see cyst and other. This is just a piece of epithelium itself. I've seen it before.
Safwan is here.
I've seen it before.
Safwan? What is what is in your mind? Let us ask Dr. Ashraf. What you kept in your mind? What is your priorities?
The only problem I made it in this. I didn't take this piece for
culture
biomicroscopy. Yes, this is what I missed. This is what I missed. I thought again after I finished the operation why I didn't do this, because for me epithelium it was more thick. Like it's more for me, it was like a mucin more, because when I'm following the patient, I think more than 3 months now. If there is any epithelium, you should have a remnant, or it should have a changes in the interface now, because for sure I can't remove all the epithelium. Something I see it and something I don't see it. I didn't do I don't use alcohol. I just wash it perfectly and remove it with a dry swab. So this case really, I'm going to follow up for a year or more than this, because this will going to give the clue. If there is an epithelium implant, it was an epithelial implant. So sooner or later, we are going to have an epithelial subepithelial remnant, definitely.
It's not necessary, by the way. Sorry for that. Ashraf, if you implanted that cells, the tissue itself, piece of epithelium underneath it, there's no sign of recurrent because there's not the normal epithelium growth where it's coming from outside. This is implanted when you lift the flap. So don't expect that you will have recurrent at all, because this is completely small piece of epithelium implanted when you lift the flap. So there's no way to recur. So it behaves different than the epithelium growth. There's no tunnel or migration. So even if it doesn't come back, it doesn't mean it wasn't epithelium from start. That's my impression.
Yes, I can't give a clue, because really I think I can give a clue. Really.
So one question, Dr. Ashraf, I know you do a high volume refractive surgery. Now on a routine basis, when you finish a refractive surgery, do you do a fluorescein stain on your patients? Do you do that, or you think that's not something recommended?
Fluorescein for what?
So after you finish your surgery and your patient is waiting in the waiting area and then they go home. So before they go home, do you put a drop of fluorescein and check, or you don't do that?
We check the alignment?
Not just alignment, like for example, the gutter, the alignment, the stria formation, anything. So, okay. I mean, is that a routine or you don't do it?
No, I don't do it. And I learned something from my professor, Dr. Fathi Fawzi. He did a very nice sign called Fathi Fawzi alignment in FEM2. After he dried the bed and he make the flap back, he put two swabs at the two edges on the two sides, and it's completely dry. Once this, you are going to have a complete gutter 270 in both sides. If you found that the gutter one side and you can see it the other side, this is not the best alignment. Remove the flap again and wash good and revert it. Once you have a complete gutter in both sides, circular, it's the best alignment. This is his sign and by his name, and he is already published.
So
I
what
think we already
exactly?
the time. Okay, so, okay, go ahead, Sandeep. Yeah.
So one of the things which I do, and I think many of the others refractive surgeons do, is just put a drop of Redford, which is the milky thing. It gives you a lot of clue, especially the gutter, how it is looking, and if you have any striae left. So I agree with you. I think
yes, I do. I do the prednisone. Yes, I do this.
Okay,
thank
can
you,
Sandeep and Ashraf stay with us also? We can check if Dr. Safwan available or not. Safwan available with us? Dr. Safwan, are you there? I think Safwan, maybe yesterday he took his vaccine. I don't know if he's capable to be with us or not. So we'll go to our next sessions. Just Sandeep and Ashraf, if you can stay with us, maybe Safwan will join a little bit after we do our session. Before that, I will give the talk priority to our colleagues. I will give my talks or my presentation at the end. So we can have now Dr. Patricio to give his case presentation. Dr. Patricio, I think there is Madhav and Nadim, they are with us here. Patricio, yes.
Hello, can you see it now?
Yes, Patricio. Can you make it in a slideshow, please?
Sure. Coming.
Okay.
Now, okay. Good afternoon or evening, depending on the country you're now in. It's my pleasure to present this case of query macular edema. And without further ado, and after thanking Dr. Alambri and the organization of COD, I will go ahead with the first slide. This is a 58-year-old lady who was referred to our unit after cataract surgery in her left eye because she did not improve after surgery. Strange, but she did not. Visual acuity was 0.5 before surgery. And she had, as something more striking, a peripheral iridectomy for acute angle closure glaucoma in both eyes. She had controlled hypertension. She was not on any medication for high blood pressure. Controlled type 2 diabetes for last 10 years. So the same for dyslipidemia. And she had an angioplasty a year ago for myocardial infarction. She was taking aspirin, atorvastatin, Lipitor, Diamicron, Janumet, and she had no allergies. So when we saw her, the visual acuity in the right eye was 0.4 from previous 0.5 at the time of the assessment for cataract, and 0.6 from 0.7. And left eye was 0.3 from 0.2, and with correction 0.5. So same before than after surgery. The exam didn't have any specific striking feature. Left eye was +1 cells, which was within normal limits for a 2 weeks operated on eye after cataract surgery. Vitreous was normal, IOP was normal, and then the dilated fundus exam showed optic nerves with capping of 0.4, 0.5. Macula of both eyes had pigment clamps, temporal 2 foveola with hard exudates. We'll see. Peripheral retina was practically normal, sonar immobilization at both foveae. These are the color pictures. We can see here some white dots around both foveolae. This is the autofluorescence with some hyperfluorescence and hypofluorescence in both eyes, specifically more so temporally to foveola. The OCT shows a thin central retina. And a closer look to the OCT, we can see some hyper reflective spots here and an area of loss of the ellipsoid zone, with which is just bands of a striped ellipsoid zone. That means there is photoreceptors loss in this area for the right eye and also for the left eye. We also can see some small cysts in the middle of both eyes. The OCTA for the left eye, the superficial plexus was enlarged FAZ. For the deep plexus, we can see some dilatations of the capillaries here and there, moderately enlarged avascular zone. At the choriocapillaris, we can also see these small dilatations, and also at the choroidal level, we can see here and here some small dilatations. So the fluorescein angiography, there is some leakage. For the right eye, there is this area here, which shows lack of perfusion and some, you will see now, some leakage. There is some ballooning here. The left eye was more homogeneous. This is the white field, well-perfused retina in both eyes. So our differential diagnosis was diabetic macular edema, pseudophakic macular edema, but was only one eye for the cataract surgery, lamellar macular hole, MACTEL2, AMD, HCQ retinal toxicity that she was not on, uveitic macular edema, and others. So we thought this is a case of MACTEL2, which is commoner in female over 50 years of age. They can develop CNV, they are bilateral, and they involve an affectation of the neural retinal cells of the Mueller cells. So the OCTs, the retinal thickness is variable, but usually there is thinning, there is never thickening, and cyst-like structures mainly at the temporal part. The treatment for the non-proliferative, there is no proven treatment. It's been tried carotenoid supplements, ciliary neurotrophic factors, and eccorbate, and all the lasers. Anti-VEGF only for the proliferative one, and smoking may be a modifiable risk factors. So what to do with the anti-VEGF? We usually leave it for the proliferative subset, but we treated this patient because we were in a little bit of doubt if there was some sort of diabetic macular edema with one intravitreal injection of ranibizumab for the right eye. And we saw a reduction of the intraretinal cyst dimension and central retinal thickness from 158 microns from 184. And this is the OCT after the injections. We still can see, of course, the atrophy of the photoreceptors, but the contour is a little bit more normal, and there is practically no cysts in the middle. So the take-home messages is, well, for anti-VEGF, only if the patient has the proliferative MACTEL2. But don't forget that patients in our setup is 20% of patients are diabetic, and they can have both diabetic macular edema and MACTEL type 2. Thank you. Sorry for the delay.
Thank you very much for an interesting case presentation, Dr. Patricio, as usual. Okay, let me now ask my dear friend Nazim Al Hussein. What do you think, Nazim, and also Madaf? Nazim, you are mute. Unmute yourself.
No, I think I came in between. I just saw the angiography picture.
Okay.
And in between I went out, but the picture is, I think it's, I don't know what you're talking about. I think it's a MACTEL that you are dealing with.
Yeah.
And the picture is very, very typical. And you can see the stellate vessels, which is going in. And the fluorescent, the dynamic fluorescent angiography is so classical of late leakage, but where you have a pigment stippling, that is where you saw the block fluorescence. You will always see a lot of intraretinal leakages, but without any having morphological changes in the OCT. So this is pretty typical. So these cases, we all know that there are chances of developing intraretinal neovascularization, and if, or possibly you can develop atrophy of the fovea with time. So these are the other long-term effect on the RP photoreceptors there in most of the MACTEL patients.
Thank you. Okay.
Yeah.
Okay. You have anything to add, Dr.
I think a nice case, Dr. Patricio. I think this case should be presented in a posterior, posterior segment complications or in a cataract surgeon, because most often, if it is not examined prior to the cataract surgery, one would probably end up with these kind of issues, not able to improve the vision after the uneventful cataract surgery. Now, as you rightly said, the patient is diabetic, hypertensive, dyslipidemic, bilateral disease. Vision is subnormal in both the eyes. bilateral perifoveal capillary dilation, in-dipping vessels. You have a subretinal precipitates all around the fovea, and you see a hypopigmentation of the macula with the pigment hyperplasia. Very typical clinical pictures of mactal type 2. And the OCT definitely shows a loss of ellipsoid zone photoreceptor loss with the intraretinal cyst. That's basically a neurosensory loss with a drape of just an ILM. So most often these kind of cases post-surgery, I mean, I wouldn't advise to give an anti-VEGF. I would have advised for a couple of months with, probably he would have done better. He or she would have done better. So I would restrict.
You mean you will do not treatment? You will not do treatment?
No, in these kind of cases, even with the treatment, the cyst has lost. But if you look at the visual acuity, it remains 0.6 in the right eye and 0.5 in the left eye. It has not improved even after the anti-VEGF, ranibizumab treatment. So I wouldn't advise. So I would restrict anti-VEGF management only.
Let us have the comment from Dr. Patricio. What do you think, Patricio?
Myopic neovascularization.
We injected the right eye, which was the eye not operated on. So we didn't inject the left eye, that was the operated on eye for cataract. We injected the right eye because I had a doubt. The patient was very demanding. I had a doubt about this area at the temporal part of the foveola of the right eye. Could be diabetic leakage, not because you see something like sort of pulling. It's not only leakage, sort of pulling. So after presenting the options to the patient agreed to go ahead with one injection, but I don't recommend usually for pure MACTEL-2. It's very difficult to differentiate hard exudate sometimes, diabetic macular edema at the foveola, if the patient already has MACTEL-2, an advanced case of MACTEL-2 like these ones with photoreceptor atrophy. So we had little to lose. We gave the patient one injection for the right eye, and as you have seen, the thickness decreased and the visual acuity actually improved one line. So patient is happy.
Okay, I think, can we have a comment from Dr. Ashraf? I think you want to say something.
Yes, I'm just going.
Yeah, very fast. We are running time. Okay.
Dr. Patricio, in the OCT, there is a thin epiretinal membrane was clearly seen, and one of them of the macula, it was very thin, nearly starting macular hole. So in injection of anti-VEGF, you don't afraid to have a little bit more traction on this epiretinal membrane to induce macular hole, or what do you think?
I don't think there was any epiretinal membrane. It was a partial vitreous detachment that you can see, yes, the posterior hyaloid there, but there were no wrinkles at all at the internal limiting membrane on the contact with the macula. And these cysts are actually empty, theoretically, empty spaces covered by the ILM. So if the patient goes to lamellar hole, the lamellar hole is already there. It's only covered by the ILM. So no, I don't think it's a very risky operation.
So we can move to the next presentation by Dr. Ziad Madanat. Ziad, can you just start your presentation?
Thank you, Dr. Muhammad. Yes, certainly. Can everybody see my slides and hear me okay?
Yes, please go ahead.
Right. Hello, everybody. It's a pleasure to be here amongst esteemed colleagues, and thank you for the Chandigarh Ophthalmological Society, and special thanks to Dr. Muhammad Al-Amri for the kind invitation to speak amongst you. I chose to talk to you about a nightmare retina case, and I hope it doesn't give anybody any nightmares after this. I'm going to talk to you about a 50-year-old South Asian male patient who presented to our eye casualty here at the Bradford Teaching Hospitals in February of this year. He came in because he had a right, red, and slightly painful eye for 3 days with a subtle blurring of vision. He is known to have diabetes type 1 that is well controlled with very mild non-proliferative retinopathy. He's known to have migraines. He is transfusion-dependent thalassemic, and he has osteopenia and has had a previous splenectomy. His vision on the day was 675, and he was found to have a right eye anterior chamber reaction. He had a pressure of 28, and he was diagnosed with a hypertensive anterior uveitis in the right eye, He was given the appropriate treatment and was planned to be followed up in 2 to 3 weeks. He was seen by one of the juniors at the time, and the junior decided to get some OCT scans, which shows some macular exudates from his diabetes and a couple of retinal hemorrhages here and there. The patient presented 18 days later, and he was seen by the junior doctor again. Unfortunately, the vision was down to 624. He still had a mild anterior chamber activity. The pressure in the right eye was normal. However, the left eye now had high pressure with a +1 anterior chamber reaction. And I'll show you his fundus pictures in a minute. On direct questioning, he mentioned some red spots on his legs, and he mentioned some genital folliculitis. So we were thinking down the line of Behçet's disease. I'll show you this drastic image of his right fundus. It's a wide field Optos image, and the picture really doesn't do it right. There's very advanced whitening of the peripheral retina. It was really just white. And there's perivascular, very subtle hemorrhaging. The central dark island is literally what's left of his retina, and that part was also damaged really. I'll show you his OCT scan. So the top picture shows you the scan at his superior macula, and you can just see this devastating loss of all retinal layers. In the middle, you see his foveal area, and the layers are a little bit better with a bit of subretinal fluid. And at the bottom bit, you still see that same devastating loss of all the layers and some vitritis as well. His left eye, interestingly, also had peripheral white fluffy lesions. They were quite small. They're not coalescent yet, but they're almost all around his retina. And he had a few vitreous cells in the left eye when I examined him, and you can see those on the scan there as well. So I decided on the day that he needs an urgent anterior chamber tap, which I performed for viral PCR. I also ordered a general uveitis screen to include Behçet's disease, sarcoid, TB, syphilis, and HIV. I arranged an angiogram for him, and I started him on oral valacyclovir 1 gram 3 times a day. I also gave him oral steroids to start 3 days after his antiviral cover. I kept him on the topical treatment, of course, and I planned to see him in 2 days. So 2 days later, the OCT scans of the right eye, as you can see, just general loss of all the layers with a little bit of sparing relatively in the center. His vision in the right eye had dropped to 636. His left eye vision remained okay. And not to my surprise, his varicella zoster virus PCR came back positive, which I had suspected in the first place. And I'll show you his ICG and fluorescein. This was really devastating. This is mid-ICG, the top left picture. You can barely see any dye going into the eye. Bottom right picture is his fluorescein. And if you look closely, you can maybe see some dye going into his foveal area, but nothing else. I mean, his vasculature was obliterated. Interestingly, his left eye lesions were a bit worse, and you can see them here on the ICG as hypocyanacid due to masking effect. The bottom right picture, you can see the fluorescein angiogram with significant loss of peripheral blood supply. This is really devastating. On day 5, the lesions kept on worsening, and the decision was made to give him intravitreal foscarnet injections to both eyes. This was done on day 5, day 10, and day 15. On the 17th day after I saw him, as you would expect in these cases, his retina started to detach really. His left eye lesions peripherally had got worse as well, with significant coalescence, as you can see. The decision was made to perform a paraspinal vitrectomy with phacoemulsification to take out his lens, do a retinectomy, insert 1000 centistoke silicone oil, and do a retinopexy as well. This went quite well with no complications. 2 months after, as you can see, his retina in both eyes remained stable with complete resolution of the left eye lesions. 5 months later, you can still see the right retina in the center is still flat. There's a bit of preretinal fibrosis that is not affecting the center. Pressure remained okay with no oil complications. The left eye peripheral lesions completely resolved on the treatment. The patient until this day is still on antiviral treatment, and he had tapered his oral steroids. Last slide, I'll just show you his OCT scan 5 months later with just complete loss of the retina peripherally in the right eye. And there's a very tiny island in the foveal area with relatively intact layers that allows the patient to see 636 really until this day. I must acknowledge my colleagues in the department, Dr. Helen Davenport and Dr. Cameron Khan's role in managing this patient. And I will stop here and open the chance for discussion and questions. Thank you again very much.
Thank you, Ziad, for an excellent presentation and excellent case. I will leave Dr. Madaf. If you can start with Dr. Madaf. Dr. Madaf, what do you want to ask Dr. Ziad? Madaf, are you there? Okay, Patricio.
Yeah, nice case.
Oh, sorry. Okay, whatever. Go, any one of you. Yeah.
Dr. Rao, go ahead. No, I don't mind.
Okay,
yeah,
let's go because of the time.
Fantastic case, Dr. Ziad Madanath.
Thank you.
think it was well recognized that it's probably a viral retinitis in the second visit to in an emergency clinic.
Correct.
So you did rightly by doing a PCR and sending it for HCV. And I just wanted to know, did you treat him with, you went to IV Foscarnet, right? Intravitreal.
Yes.
Intravitreal
Yes. So
Foscarnet.
this wasn't started in the beginning. We started him only on oral, but because the left eye lesions were getting worse very quickly, the decision was made to start him on the Foscarnet. You know, the worry with these cases is two things. The Foscarnet is retinotoxic, and also you are performing intravitreal injections in a patient with viral retinitis who is at very high risk of retinal detachment. So you have to try your best to avoid any traction on the vitreous as well.
I think the surgeon has done a fantastic job, because this is very difficult surgeries to induce the PVD. It will cause, because of the sieve-like nature of the retina, peripheral retina, they have an extensive tear, you know. He has done extremely good. If you look at the post-op pictures, he has got very less gliosis, though the optic nerve looks pale, I mean, which is expected.
Okay, I will ask you, Madaf, if you don't know that, I mean, now after the diagnosis, what it came to your mind if you saw the picture from the start?
Well, in these cases of, you know, you should suspect you should have a high suspicion of retinitis, viral retinitis. So in the beginning,
if you want to give a message, what is the, I mean, the indication that make us that highly suspected of retinitis? I mean, just for our sector, those
look for a cell flare, both in the anterior segment or in the posterior segment. Look for a panoramic view of the peripheral retina. Never, you know, always dilate and look for the peripheral retina, and if possible, try to do a complete evaluation with an angiogram, ICGA in the first instance itself. If you find vitreous cells,
is there any pathognomonic feature that we can depend on?
Yeah, the multiple retin vascular changes with sieve-like breaks. It's very typical of viral retinitis.
Okay, Dr.
The patient
Patricio, if you have any comments?
Himself would say about the viral retinitis.
Okay, Patricio?
Yeah, a nice case, as I was saying before, very well managed promptly. But I wonder, was this patient on systemic immunosuppression, or was the patient, let's say, immunosuppressed by any other means? Because it's so virulent. These devastating cases, usually they're associated with some sort of systemic problem, be it immunosuppression, cancer treatment, whatever. Also, maybe the patient was on blood transfusions, I don't know, but maybe it was related to the blood transfusion. So I wonder if you really were able to pinpoint where all these things and why it came from.
Correct. You're absolutely right. And we had this discussion in our own MDT here. So as you correctly mentioned, the patient is beta thalassemia on regular transfusions, and he had already had a splenectomy, which can give you relative immunosuppression in some cases. And I looked at the literature. There's not much cases like this, to be honest with you, and we're in the process of publishing it. So you're absolutely correct. I think his regular blood transfusions may have been a risk factor, because he never gave any history of having shingles or having varicella zoster virus disease. And also, I think his splenectomy may have played a role as well in having such a virulence.
Okay, we have only 1 minute. If we can have Dr. Nadeem also, if there is any comment. Sorry to interrupt you, Dr. Ziad.
No problem.
Nadeem? Is there Nadeem here? Okay, Dr. Ashraf?
How long you are planning to keep him on oral antivirals?
So we were having a discussion with him. I saw him just 3 weeks ago, and there is no evidence to tell you exactly how long you should be treating these cases. And he's still on oral antiviral treatment until this day. We've advised him of the possible side effects. So the answer is indefinitely for now, so far that he's happy and he's not getting any side effects of the oral valacyclovir.
Okay, thank you very much. Anyone want to give only in 10 seconds? Ashraf or anyone, Dr. Nazim?
Just to say, does the patient was not known to be Behçet disease before?
No. So he mentioned he had some red spots on his legs, and he mentioned genital folliculitis. And you're absolutely correct. And to answer the question about the pathognomonic signs, when you see subretinal fluffy white areas there, this is either viral retinitis or Behçet's really. There's not a lot of things that can give you that. On testing, all his immunological investigations came back negative, including his HLA-B51. So we don't think he's got Behçet's. We think this is purely VZV related.
Thank you very much for this case. I will give a very fast, I hope it will be a very fast presentation from my side. So I will talk today actually about my real world experience with using brolucizumab in naive patients. I have several cases just to show our experience. This is a first case. It is a 72-year-old male patient, not diabetic or hypertensive, no case of wet AMD bilateral. I was treating this patient for a long time period, and he was taking around 20 ranibizumab injection between 2016 and 2019. And he was lost for follow-up for 15 months before he came. So the first eye, we saw that the right eye is visual acuity 0.5, left eye counting finger 50 centimeters. So, and we found him that he's having a wet AMD and OCT showing 700 in the right and 600 in the left. So we started the left because this is our first experience with using brolucizumab as the treatment of wet AMD. And this is the OCT of the left eye pre-injection. You can see about 600. And this is the video actually of the patients. OCT video showing how is very high edematous macular edema. So we give the injection, and first week post-injection, you can imagine it was improving from counting finger only in the front of the face to 0.5, and the pressure was within normal, and the OCT was about 353. You can 350. This is just 1 week post-injection. You can see the change. And this is the video of just 1 week after the first injection, 1 week. And this is the comparison, because for the sake of time, I'm going a little bit fast. So this is pre-injection. Before injection, it was 600, and 1 week only after injection, it became around 200. And 1 month after first injection, and this is after the third injection, we are having the vision improvement to 0.1, and OCT become 156. This is the OCT video for after the third injection. So the second case is it will be only the right eye of the same patient, and you remember he was having a vision of 0.5, and the OCT was 700, and this is the picture of the video, sorry, for the pre-injection. And this is only 1 month post first injection. Now we are having more eager to do, and we are a little bit have an experience. The first one, we used the 3 injections. So now we didn't do 1 week, we do 1 month after the first injection. And you see, and this is the video, 1 month post the first injection. And this is the comparison. You can see before, and this is after of the injection. 1 month after the third injection. So we have give 3 injection, and this is how is the result. There is a good improvement in the visual acuity, and this is the video. It was 0.3, we reached from 0.05. So there was a completely resolve of the macular edema, and at the same time improvement in the visual acuity. This is the third case, as a 20-year-old male patient, no case of diabetic and hypertensive. This also patient lost for follow-up for 5 years. The visual acuity on the right counting 0.3, and the left out counting finger. He's having left eye pseudophakia, right eye early cataract, and we found right eye dry AMD left eye wet AMD, and I decided to give also because we lost follow up for this patient. He was not treating actually by anything. It's this one, the first time I treat him directly with POV. And this is the OCT before the injection. And this is 2 weeks after the first injection. And this is 1 month after the third injection, visual acuity improving from counting finger to counting finger 1 meters. There is not much improvement in the visual acuity, but it will make a difference actually. Still, the little improvement in the AMD, it make a difference. I think I will stop here because we are running behind the time, and we will. I'm ready for any question or any.
Yes. I'm sorry to
interfering.
interrupt, Dr. Amri. We have plenty of time. We have another 20-25 minutes, and it's a wonderful session going on. So please feel free to have the discussions and carry on because they're such wonderful cases. We still have 20 minutes.
Safwan is there. Is Dr. Safwan is there? Okay, I don't know. Do you want me to continue? It depends on Dr. Madaf Rao.
We do have 20 minutes.
Dr. Madaf and Dr. Patricio. You want me to continue or it will be the same? Actually, all the cases, just we are showing here only our experience. I think we will keep it for the discussion is more better.
Carry on, sir.
Yeah, go on, go on.
Go on, please.
This is the fourth case. This an 80-year-old female, known case of hypertension, had both eye Avastin injection. Had both eye Avastin injection before 4 years. On examination, the visual acuity in the right eye, just counting finger in front of the face, left eye hand movement. So we found in the right eye, which is a pseudophakic wet AMD, left eye, there is a cataract and no view for the patient. And actually we are in this time, the period of time we could due to COVID, we are not able to do a surgery. So I start giving an injection in that eye, which is the, I think right eye, sorry. So this is the OCT of the patients before the injection. And this is the video of the patient pre-injection. You can imagine a very huge and a lot of macular edema. And this is just 1 week after the first POV injection. And this is the video. You can see the difference. Not that similar to the previous one because here a lot, it was a diffuse actually macular edema with central involvement in a very more than 700. This is the OCT after the first injection, 1 month after the first injection. You can see now it's become very, very nice. And this is the video. Second, after the second injection, it's become more and not better. And the patient also improving from also counting finger, or I think it was hand movement on the right eye to counting finger 1 meter. And there is a lot of change in the OCT here. You can see the central retinal thickness become only 117. And this is the video after the second injection. So the take-home message, sustained dryness was achieved faster in brolucizumab-treated patients versus aflibercept. Fewer injections were required in those patients compared with aflibercept. In early real-world experience with brolucizumab, OCT biomarkers show a good improvement. Brolucizumab demonstrated better control of fluid in patients. And thank you very much. So before I end this one, just I want to invite dear colleagues in Chandigarh to our third conference, third MIOM conference. It will be in 23rd to 25th of September 2021 in a virtual platform. Just now we will open the discussions, and if there is any question, Dr. Madaf and Nadeem, anyone of the panel here, Ashraf, anyone.
Dr. Muhammad, if I may start, this was a very interesting talk. And I have a couple of questions for you. Well, first question is, With the Beovu, have you noticed any cases with intraocular inflammation? And if so, how did you manage them?
Fortunately, no. I didn't face until now any. I have so many cases, and I have the privilege to be me, I think, and Dr. Madhav Rao, the first, maybe surgeon, the first ophthalmologist to use Beovu in UAE and in the Middle East. Is that right, Madhav? He's having also a couple of cases of experience. Now we are having 1 year of experience. I have so many cases. What I show here only a naive patient. That's, I didn't use any previous, but fortunately for that, until now, I didn't face any case of any kind of inflammations.
That's fantastic. That's fantastic. And the second question is, you can use the Beovu as rescue treatment, as you showed, and in naive patients. Do you use the same treatment regime? Do you give 4 weekly loading and then extend, or do you give first treatment and then extend after the first treatment?
There is a different protocol, I think, for using for Beovu. We are giving a 3 loading dose. Then we give every 3 months. This is the usual, unless there is, there is no response, or there is some, like if there is after the 3rd injection, then you will wait 3 months, or you can 12 weeks. If you find the vision is deteriorating, or there is an increase, after you can go back. I think if Madhav, he can correct me about that. And go back and to start in after 8 weeks. But most of the time you are using in 12 weeks.
Fantastic.
Dr. Ziad, according to the Hawk and Harrier study, the proposed number of injections are in the match phase with aflibercept is 0, 4, 8, 3 doses, followed by a disease activity assessment after 8 weeks.
Correct.
And then if there is no disease activity in terms of visual acuity and the activity of the disease on OCT, then you can extend 4 weeks further, you make it 12 weeks. And then if it falls into 12 weeks, you continue generally with the 12 weeks. So this is one beautiful point about the Beovu or the brolucizumab, is about the predictability. Once we are in the group 12, it is almost like 75% of the times it would stay in group. It would remain in group Q12. And that's at the end of 50 to 48 weeks. And the second year, till 96 weeks, the predictability goes higher till 80%. So this is one of the best thing about the predictability of Beovu. As of now, we didn't have any predictability when it comes to ranibizumab or the aflibercept. Probably we would have extended with all of them. We would have extended by 4, 6, 8, 10, and 12 weeks.
I think aflibercept, aflibercept, they are talking about they can extend up to 16 weeks. But we are talking about what is proved, and actually we have,
clinical trial
study about that, and it's only for brolucizumab.
What we have seen is about the fluid, the complete absorption of fluid, whether it is intraretinal, subretinal, and the sub-RPE, is something unique.
It's quite satisfying when you see
very satisfying.
Respond to
whether it is a naive patient, whether it's a naive patient or with the switch. We have seen today. I was seeing one of a patient on brolucizumab. She has a deciform scar in our right eye, and the left eye we had switched from aflibercept for some reason. She had an activity every time she used to come back at 14 or 16 weeks. We tried it out. Now it is post 16 weeks. I see the macula to be dry. So that's one of the best. Yeah.
We've had in our region in Yorkshire in the UK, we've personally had more than 50 cases on Beovu. All of them were rescue treatments. Unfortunately, we can't use Beovu still as naive treatment due to the guidelines, but we've had experience in more than 50 cases as rescue, and luckily the vast majority of them are doing very well, and we're able to extend them as well. So less number of injections per year, which means less risk of devastating complications like endophthalmitis.
Yeah. Do you have any complication? Did you find any intraocular inflammation in the cases that you are treating, Ziad?
In the audit that I did, I looked at 50 cases. There was only one case that developed very subtle perivascular sheathing. So it wasn't an obvious inflammation. When reviewing the pictures, the patient developed perivascular sheathing around one of the veins. And the decision was made to stop the Beovu and start oral steroids for that patient due to the worry that it might lead to vision loss. Luckily, the patient is fine; they did not lose vision. No other complications were found in our patients, thankfully.
Just for an information, because there is a difference between inflammation. What we need is uveitis or simple things that can be treated easily. What we are afraid only about what is called vasculitis. This is the most important, difficult things that we are afraid, or we have a fear from that. But I don't know until now, fortunately, and I think the real world, it's not similar what it was mentioned in the Hawk and Harrier. Is there any comment from Dr. Patricio or Madaf, or also Ashraf, you want to join us? Dr. Nadeem, you are there, I don't know.
Just one thing, do you review your patients in between injections, looking to the peripheral retina, small vessels, looking for vasculitis?
This question for me?
For anyone using the...
Okay, for me, actually, what I'm doing usually, we are, whenever when there are, they are coming back to us for follow-up, we do a dilated fundus, we see him, we do an OCT, and I do also at the wide field for all the patients, just to be sure that I cannot see anything. And I'm examining the patient for the periphery, especially in the beginning. Now, the most important, you have to examine most probably after the second injection. They are thinking that it will be more higher to have the vasculitis. I don't know, Madam, I'm correct or not, and also Ziad, you can correct me. That's what I do remember. But usually, we are in the beginning, I was bringing my patient after the second, after 1 week to examine properly. Then after 1 month, then after injection, each injection by per month, 3 times, and also after the third injection. Also in between, before we reach to 3 weeks or 3 months, 12 feet, I bring them in the middle, also 6 weeks, also to check this patient in the beginning. Now it's not, we are trying just after 1 month of the first injection, then after 1 month after the second injection and third injection. And we are telling the patient, if you feel anything in your eye, if you feel any pain, any flutters, whatever, any change in your eyes, I give them even my mobile number. They can call me anytime. So I can discuss with them in the phone and bring them in the second day if there is any suspicious. This is my way how to deal with the patient, because they are not much, in our area, AMD not that much like another places, maybe in India or in the Western country. We are having a very few, most of our patients diabetic macular edema. But we are taking care for that, and we are following the patient in this way. I don't know, maybe we can ask Madaf if he is doing something different.
Well, I just keep it as simple as any other intravitreal procedures. I do explain them with the symptoms of if they were to develop any symptoms like redness or drop in vision, especially complaints of shadows, to report back at any point in time. It could be a first week, second, or the week later. So generally, I don't call them. I see them at the end of a month.
Okay, good. Yeah, the thing is with Beovu, we're all looking forwards to get rid of the burden of consultations and injections and the like, and it is just the opposite. We are seeing the patients more often, and at least for the loading dose, it's a nightmare. The objective was completely gone, completely missed.
I mean, in the UK here, I completely agree with you, Dr. Patricia, is that the objective is to reduce the load. And here in Bradford, we look after thousands of patients with AMD, diabetic retinopathy, vein occlusions. And unfortunately, we don't have the capacity to see them every 2 weeks. However, we depend very much on the ultra wide field images. And I must say, they are a very, very valuable tool to have in managing these patients, because it's very difficult for clinicians to have a look at a patient and say there might be a little bit of sheathing here and there and it's got worse. Whereas if you look at the picture, you can detect it easily. We give the patients the questionnaire, and we tell them, we advise them to report any redness, floaters, and everything that's been mentioned by colleagues now previously, to report it straight away. And we also examine them thoroughly on the day. We also in Yorkshire have it's a mini protocol really when treating patients with Beovu. Any patient who's had previous uveitis is excluded, really.
Yeah.
We don't tend to give Beovu to any patient who's had previous documented uveitis, or any patient with single eye. If they have one seeing eye, we tend to avoid it, just because also, as I said, with the guidelines, Beovu is not fully licensed in the UK just yet.
Okay, Dr. Ashraf, I think we need to hear Dr. Ashraf. I know it's anterior segment, but every anterior segment can do also posterior segment nowadays.
Yes.
So,
I'm just
why you are laughing,
Madam?
madam? This is the truth. What to do?
No,
they are trying to catch. They are trying to put their hands in our work. What to do?
Usually in England, the posterior segment don't do the anterior segment work. Also, the glaucoma don't do the cataract. This is, I think, this is true. Yeah.
Don't say yes. Don't say yes. Don't say yes.
It's not entirely accurate, but we tend to try and avoid. I'm trying to be politically correct here, not to upset anybody.
Okay. Yeah. So if you combine, what do you think, or what's your experience, Dr. Muhammad, when you combine this with the cataract? Do you find the first week the eye is not quite?
I didn't. Sorry, the question. Can you repeat? Sorry, I didn't get you. Sorry.
When you combine the injection with the cataract in the same session.
Okay.
Did you find the eye is not quite in the first week, or mild ciliary injection, or mild subtle inflammation?
With brolucizumab or in general, I didn't do any.
Yes.
I didn't do.
No, brolucizumab.
In brolucizumab, I didn't do with cataract. I have never do until now any procedure with brolucizumab injected with cataract. No. But other anti-VEGF, I can give my opinion. But if you are asking particularly about brolucizumab, no, I didn't give with a cataract surgery. If Dr. Madhav give, you give with brolucizumab with cataract surgery?
Well, Dr. Ashraf, as of now, the indication for brolucizumab is only for wet AMD. And I don't think
maybe he thinks there is an AMD at the same time there is a cataract. So, it can be.
We need to rush in for a cataract surgery with the AMD management as of now. That's one. As far as
because we usually give
answering to Dr. Patricio's question, are we taking it too seriously, all these intraocular inflammations? If you look at the recent, the SRC published by the team Novartis, they show the intraocular inflammation with retinal vasculitis and the sight-threatening vasculitis and the visual loss is much less in the real world data. So I don't know, are we taking it, are we bringing back all the patients who have been injected with brolucizumab? I would say probably no. So that's the reason I said probably you just have to explain them, make them understand that there could be some subtle difference between the intravitreal injections, but need not bring them back so often.
Fine.
What do you think, Patricio?
Well, I think that the data is showing that there are some higher risk of occlusive vasculitis, inflammation, and endophthalmitis than with the use of the other anti-VEGF. So that's up to you how you want to follow these patients. But I'm thinking of the legal case that ends up in a court. The papers are there. We should take all the precautions for these patients. I know we are busy.
We should. There is no doubt about it.
We are busy. I agree with Dr. Madinat. I would use Beovu as a niche, as a last resource, mainly because of the legal implications if you get one of these complications. And you know that when one of these patients goes south, they can actually end up in court. And that,
if you allow me to comment, Dr. Patricio, there is a new weapon in between our hands. And it can improve the vision and improve, we can tackle the edema in wet AMD very nicely. There is a complication. Nobody denied there will be, but it is very minimal. It is 1%. If you talk about any medication, there is a side effect. I'm not here to, I don't have any financial interest, by the way, but I'm thinking, why not use this medication? It improved very nicely. What I saw, it is really a magic. Within 1 week, you can see it's completely dry. I think if we use this medication in the beginning, whenever the vision is still 0.8 or 0.7, it will be amazing, and maybe it will be give us a long period of time of follow-up, and we don't have the many deterioration of the patient. It will be less if we compare when we are dealing with other anti-VEGF in treating with the MD. This is my opinion. Actually, it's a primitive experience, but I feel now eager to give, and I am happy to shift all my patients to this medication. And as we start, before we was having Lucentis, then it came Eylea. Everyone saying, well, it's not. There is some. We found some also complication happened one time due to aflibercept. But still, it was a good one, and it was a very nice medication. And now there is another new one. We hope we'll get another in future. So the future is going on, and the technology and the medications and method of treatment, which we don't stop unless there is something very serious. But the seriousity, we have to take care of the patient to discover the complication immediately and to treat it, and it's easily to be treated. I think Dr. Safwan is trying to, he gave me a call that he's trying to connect, and he couldn't until now. He is trying. I don't know if he will. Dr. Safwan, did you? Dr. Safwan here. So there is a time for us, Dr. Malhotra, we need. Dr. Safwan is a big boss. If he didn't present his case, he will kill me. So if you allow me that Dr. Safwan to give his presentation. Is that okay?
Yeah. I will do my best to be with the.
Okay. Very fast. We are having 5 minutes.
1 minute. Just let me prepare. If you can just skip me, because I was hurried to join. So okay, from the clinic, just give me 2 minutes to 3 minutes. I will finish the story.
It will be too late for Safwan to 2 minutes, 3 minutes. Okay, go ahead. You try your best.
Okay.
Dr. Shantan, just whenever the time is finished, we give us. We will stop.
Yes, you can take another 5 or 6 minutes, Dr. Safwan.
Okay, so yes, I will share my screen now.
Go ahead.
And it will be in this way. Okay. Now you can see my presentation.
Yes, go ahead, Safwan, please.
Okay.
Yes.
Now my case presentation for how to select a special lenses for a special patients. And precisely, I'm talking about a special hybrid EDOF lenses, and when we can select it and to which patient we can select. I don't have any financial disclosure here. The first case, female patient having 73 years old, post-hyperopic LASIK, both eyes. Patient want presbyopic treatment and do not need to use any glasses. If we will look at her refraction, we will see that her refraction is within the right eye plus 0.75, minus 0.75, and minus 0.5, minus 0.25. This is after treatment. The important things here, post-refractive surgery, is to look at the high order aberrations. If we will look at the high order aberrations here, she is within 0.5 and 0.62. The key reading here is not, I will show you in the corneal map, it's not exceeding 46 central. Spherical aberration 0.05 because it's hyperopic, and comma here 0.3, 0.4. So I select this patient for trifocality. And if we will look at the second patient is a myopic 63 and have a refractive error of -1 on -1 and +1 on -1. Again, spherical aberration 0.28, 0.4, and comma is not exceeding 0.5 in both. Now, corneal map for the first one shows clearly that the key reading here, central, is not exceeding 46, and that important things to select patient for multifocality. And the higher aberrations, as I explained to you, that comma is important things here for me, and it's not exceeding 0.5. The left eye having K reading 48, and that was one of the issues that I crossed it here because the lens is different than the diffractive trifocal lens. Coma here in this eye is 0.41, and it's not vertical, it's against the rule, the comma. Now that's for the second patient, is the myopic. And in this patient, the higher the abrasions is within accepted level, the comma 0.49 and the total is 0.59. That for the right eye. For the left eye, as you can see, that the comma is 0.5 and the total 0.65. Here, in those patients, there is an option that we need to use it to correct or to reach their demand or their goals. That we have a few cases, few lenses available now in the market. The EDOF diffractive, both eyes, or EDOF refractive for both eyes. This is my question to have to be a choices for these patients, or trifocal diffractive refractive with EDOF refractive, trifocal diffractive or refractive, or EDOF pure monofocal with a spherical abrasion. What I choose for this patient, because post-refractive, I choose the EDOF with refractive, EDOF with refractive add, or refractive EDOF, refractive with EDOF add. And I choose them because of this specification of this lens. This lens available in our market in name of Lucidus refractive. This is the optical issues that shows the ability of this lens to reduce the photopsia, because our aim in post-refractive is to reduce the photopsia that expected if we will use a diffractive or pure refractive. And by adding the EDOF add to the center, we are reducing either the diffractive or the refractive element of these lens. In this case, we are reducing the refractive element, so we are reducing the post-op photopsia, and we are enabling the patient to read. That's why I use this lens. So I put for both patient Lucidus, and Lucidus give an add of +3, which means around 2 diopter on the cornea, comparing to patients with a classical trifocal, that it gives a 3.5 on the level of the lens, which means 2.5 on the cornea. I will go to end. That's the post-op. Post-op for those patients, usually I'm using micro monovision to compensate for the difference between the trifocal and the EDOF refractive. So I'm using, for example, in this patient, that the hyperopic minus 0.75, that was my target, and minus 0.5, and that's what result in, and his vision 0.9 for both, with corrected also on the right 0.9, but 1 in the left, but he end up with N3 in the right and N4 in the left, and he's very happy without any photopsia. The second patient, he end up with minus 0.5, minus 0.25, with N3 in the right, N4 in the left. So EDOF that reduce the central power from a refractive or diffractive, adding a spherical abrasion as an add around 1.5, give us a chance to implant these lenses in post-refractive cases. Great, thanks. Dr. Mohammed.
Thank you very much, Dr. Safwan. Is there any questions from Usama, Ashraf, Sandeep? Any comment?
That was Ashraf? A very nice and interactive session, Dr. Amri. Nice case presentations and discussion, and it's really an interactive one which I've heard. So a great session, and you finished right on time. I mean, even though there was some delay, but yes, thank you so much for this wonderful interaction. And once again, thank you for inviting us to your conference in September, and we hope to be there with you in September.
Inshallah.
Thank you, everyone.
I would like to thank you for your inviting me to participate in Chandigarh Ophthalmic Society virtual platform. It was a great, and we are having an honor to participate with you in this session. And it is also honor to be with us in September. Can we have only 1 minute, only if there is any comment from one of Dr. Ashraf about Dr. Safwan? Is there a time?
I think we have to move for the oration, which is very important. So if we can just have one question. I mean, if we can have
only one question or one comment. Yeah, Ashraf, if you can go very fast.
Yes, one question. In these cases, you don't prefer monofocal IOLs, with the monovision correction?
Dr. Ashraf, the patient refused the monofocality and refused monovision. So here, those patients, they are very demanding, and they don't accept the monovision, because what they have as a refractive surgery, it was not a monovision. So that's why I select the EDOF lucidus.
Thank you very much. At the end of this session, I would like to thank Chandigarh Society by the president, Dr. Gaspret, is in front of us, and Dr. Professor Shantan for their kind invitation and their support during this meeting. And I would like to thank all my dear friends here, starting by Dr. Nadim Al-Hussein, Dr. Madaf Rao, and Dr. Sandeep Mitra, Dr. Safwan Bayati, Dr. Osama, Dr. Ashraf, Dr. Patricio, Dr. Ziad Madanat, and also Dr. Myself. I would like to thank myself also, if you allow me, for being with you here.
Thank you.
Thank you very much, and we hope to see you, inshallah, in future. Thanks a lot, and goodbye.
Thank
goodbye.
you.
Good night.
Thank you, everybody.
Thanks
nice
a lot.
to see you. Bye-bye.
Thank you very much.
Bye-bye.
Thank you.
Bye-bye.